Yeah. Good morning. I'm Hélène Langevin. I'm the director of the Osher Center for Integrative Medicine, and it's my pleasure to introduce this morning's Integrative Medicine Grand Rounds. So what we've been doing over the past 9 months, 9 months, has been having each presentation has been by a different center for integrative medicine throughout the Boston area. And to close the year, we're very happy to, the first presentation was by the Osher Center, and now we're going back to the Osher Center. And our presenter this morning is going to be Dr. Don Levy, who's the medical director of the Osher Center. And I just want to say that I will be filling in for Dr. Peter Wayne, who unfortunately is not here due to an illness, and we wish him a prompt recovery. Dr. Levy.
So today I'll be speaking just as an introduction to integrative medicine, and then we're happy to have our guest speaker, Dr. Sudarsky, who's an expert in Parkinson's disease, Art Madore, who does core integration, core movement integration, Feldenkrais-based, and Peter Wayne was going to be here. Helene's going to fill in for him. My intro is just to say a little bit about integrative medicine. I'm the medical director of the clinic, and integrative medicine, I think it's really an attitude of mind that prefers, at the beginning of any illness, non-invasive, minimally, perhaps non-pharmaceutical approaches to care that help stimulate one's innate ability to heal, maybe teach us how to take care of ourselves through whatever the illness is, and then it always generalizes into lifestyle changes, which means exercise and diet, and then, of course, dietary supplements. And then we get into a whole collection of things. So if someone was coming to see me, all of this, which I will not speak about today, except briefly, are the kinds of things that come up. And people that come for integrative medicine consults do not do so to replace conventional medicine. They often choose both, and they're very excited to be at a hospital where they can have both. In fact, today's patient was referred by Dr. Sudarsky, an expert in Parkinson's disease, to someone in our clinic. If you were to arrive in my office, I always ask people what Dr. Google said, because Dr. Google's on call all the time and seems to present a lot of information to people. And there's a list of things that people want to try, and some of them that have some degree of evidence I've listed here, and I could show you papers on just about every one of these, maybe 100 papers on Tai Chi, and 5 or 10 on others. I only have one on dance. Tango beat out exercise in a randomized trial for balance, and I bet there's more. I just don't have them. And what we do is discuss which one of these makes sense for that person. Then we get to what people think is the heart of integrative consults, but it isn't, the nutritional things and dietary supplements. And I'll just mention 2 things. One is, for a long time, I thought coenzyme Q10 had great evidence to support its use for Parkinson's disease, especially early on. But when 2 really good studies came out, that just didn't bear out. And so I tell people to save money. In the beginning, it was good for people who had not had medication. That looked good. And then it was tried with people who were already on medication. It did not work. And then a better study with people who are naive to all medication showed coenzyme Q10 is probably not worth it. So that's part of coming to a reasonable consult, to talk about a rational approach to things. There are many things I've left off here. Today, we're sort of on the left, the things in yellow, the whole left side. We're going on the left side today. Mind-body manual therapies, Feldenkrais-based. Alexander, Art calls what he does now a combination of several things, of Feldenkrais and neuromuscular, and what some people call sensory motor agility, and we'll hear a little bit about Tai Chi. The main point I wanted to make, though, by the way, all of this, 3 very formative teachers in my life are listed at the bottom there. No, that's on the next slide. I'll show you that. On the bottom, this next slide, which is really my last information slide, Culture, Illness, and Care is an article written by teachers of mine, Leon Eisenberg, Byron Good, and Arthur Kleinman, who really were the founders of the Harvard School of Social Medicine, which is now the School of Global Medicine and Global Health and Social Medicine. They were the originals, and they had an enormous effect on me and the way I look at medicine and life. So my final point is that there is a distinction that they came up with, and others have said since, between a disease and an illness. The disease is easy to at least conceptualize. It's the pathophysiology. It's the biomedical part. You'll hear things like dopamine and substantia nigra. and you'll hear about particular medications and management, and more about the pathophysiology. The illness is what happens to a person with the disease. And this is central to me. It's changed my life thinking about this. It's the person who is ill, how we perceive, how we experience, how we wonder about the different symptoms we have, how we suffer, how we worry, how when if a person with Parkinson's has numbness in their left foot, which they never had, is that a bad thing? Do I call Dr. Sudarsky and find out, or whoever is treating me? What does it mean? What am I like as a person? How long did it take to get here today? It used to take me half an hour to get ready. Now it takes 2 hours. That's the illness, the person trying to adapt to something very serious that's happened in their life. I had a particular experience early on watching a patient whose life, I was assigned to interview someone with Parkinson's, and he started to weep at some point in his presentation when he's a meticulously dressed person who said what happened to him was at a meeting, he was leaning and he drooled into somebody's food. This changed his life. Now, drooling, sialuria, it's got a name, it's part of the pathophysiology. Drooling into somebody's food was so, I don't think he left his house for the next year. It was just devastating. That's the illness, all those parts that make us, that we humans suffer when we have a disease. So I was going to end with a couple of things that are important. I think when you deal with the person, you deal with their suffering, and suffering leads to a way to find hope. And Art found a quote from Tom Grayboys, who has Parkinson's disease. I think I'll just read it. You can see it. The soul is where hope lives. Tom Grayboys is a famous cardiologist in the Boston area. It's where hope lives, not a naive hope that I will, by some miracle, have my former self restored, but hope that tomorrow and the day after can still be days from which a measure of joy and meaning can be derived. And from hope springs optimism that even with great limitations, there is life to be lived. So I think that the aspect of treating the illness is treating that part of the person that's looking for a pathway to hope, some part of my life to be lived. There's a crucial moment in everyone's life when they become chronically ill with anything in which they realize this: things are never going to be the same. Things are never going to be the same. And from there, it's a time to start saying, well, what will we have together then, or in a family or in a group, or even if they live alone. So today's presentation is about the 76-year-old woman who has Parkinson's disease and how an integrative team can help her manage her disease and her illness to help her continue to discover that, what he writes here, even with great limitations, there is life to be lived. So I was going to start by having Dr. Lou Sudarsky talk about, he does more than the disease, too. He's our disease expert, but I know from his practice and what his patients say, he treats the whole person, and these concepts are really fluid and just something to think about. Lou's going to talk about, as a Parkinson's expert, what the disease is about and the illness. And then he referred his patient, Madeline, to Art Madore, who'll tell you what he did. And then we'll have a little bit about Tai Chi that Helene is filling up for Peter, because Tai Chi is a big area of interest in Parkinson's. So, Lou, I will move you to...
Okay, thanks, Don, for that nice introduction. When I first met Madeline, she was 68. She came in complaining about a stooped posture, a tendency to scuff the feet, particularly when tired, slowness getting out of a chair, difficulty to dance. She had constipation, often an early feature in Parkinson's disease. On her physical exam, she did not have a characteristic resting tremor, which not everybody has, but had a degree of slowness and stiffness, bradykinesia and cogwheeling in the limbs, and a gait that I would probably describe as cautious, slow, hesitant, reduced swinging of the arms, and a tendency to topple over backwards when displaced backwards, a tendency to retropulse. The diagnosis of Parkinson's was suspected by our colleagues who referred her, and she was started on levodopa to replace dopamine, with what she described as an amazing improvement. So then when she got to us, we kept her on levodopa with carbidopa, the principal medication for dopamine replacement in Parkinson's disease. And she participated with us in a 5-year NIH-sponsored clinical trial with looking at creatine, an antioxidant, mitochondrial cofactor, to see if it would slow disease progression in Parkinson's disease. 1,760 patients, she participated in the randomized trial. And it was a negative study. Like coenzyme Q, creatine does not slow progression in Parkinson's disease. But anyway, she was on her principal medication the entire time. And at 6 years, she was on 500 milligrams of levodopa with carbidopa and 1 milligram of rasagiline, a monoamine oxidase inhibitor. She complained that the pills would wear off after a couple of hours, wearing off heralded by a return of stooped posture and shuffling gait, the same symptoms that she complained of at the time of her presentation. She exhibited a distinct degree of bradykinesia, slowness for finger taps and for heel and toe taps, the left side limbs. Hypophonic voice, for which we referred her to Lee Silverman voice training, a very specific kind of speech therapy that we use to encourage more voice volume in Parkinson's disease, and referred her to Dr. Madore for help with her stooped posture. So a word or two about Parkinson's disease, which is the second most common neurodegenerative disease. It remains, despite all of the progress and all of the science in the last few decades focusing on this problem, it remains basically a clinical diagnosis, the same as it was in Parkinson's time. There are no lab tests. It's recognized by its characteristic resting tremor, often asymmetric at the time of presentation. There may or may not be a tremor. In her case, there was not. There's often rigidity or cogwheeling, which you can appreciate on physical exam. Bradykinesia, slowness, is the most disabling feature, and the research diagnostic criteria require that there be some bradykinesia to support a diagnosis. Also, stooped posture, shuffling gait, the least specific presenting features. To some degree, it's also a diagnosis of impressions, as you see in these drawings from Gower's textbook in the 19th century. You can see the very characteristic loss of facial expression, stooped posture, which characterizes the disorder, tendency of the handwriting to involute into a tiny scrawl, hypophonic voice. The disabilities related to the loss of dopamine in the brain due to the loss of the dopamine cells in the substantia nigra. Here you see these pigmented cells contain melanin, manufacture neurotransmitter dopamine, and you see them in various stages of illness, including some extraneuronal pigment in a couple of cells that have given up the ghost. There is a characteristic marker in the neuropathology, which is this eosinophilic inclusion, the Lewy body, and the neuropathologists generally require this. If they don't see Lewy bodies, they won't sign the case out as Parkinson's disease. These contain alpha-synuclein, a synaptic protein, which is increasingly recognized as one of the principal drivers in the neuropathology. Alpha-synuclein accumulates in the brain in Parkinson's disease, much the same way beta amyloid is driving the pathology in Alzheimer's. So here you see Lewy bodies and Lewy neurites that immunostain for alpha-synuclein. So what then is the cause? Well, we recognize this now as a complex neurodegenerative disorder, a combination of genes and environment. Genetics is important, but not necessarily the dominant driving feature. It's complex genetics, not simple Mendelian genetics. If you have about 10% of patients have an affected parent or sibling, studies of twins show concordance in 10 to 15% of monozygotic twins. And typical Parkinson's onset over age 50, probably not something you inherited in a simple fashion. But under the age of 50, there have been a number of single gene mutations that have been identified that cause Parkinson's with young onset and more classical inheritance. The mutations in alpha-synuclein are an important signal to the scientists who work on this, because this is, of course, the protein that over proliferates and accumulates. Too much is made or not enough is cleared that contributes to the neuropathology. The most common of the single gene mutations is is the most common of the gene mutations is the LRRK2 mutation, which accounts for about 5% of familial Parkinson's in North America, 2 to 3% of sporadic, 20 to 30% of Parkinson's in North Africa and the Middle East, where this gene mutation arose. So complex disease, combination of genes and environment. There have been a couple of decades of environmental study trying to figure out what the relevant exposures and precipitants are. Slightly increased risk in people who have been exposed to agricultural chemicals. People who've worked with metals, as in a foundry, have a somewhat increased risk. 2 significant environmental exposures that reduce the risk of Parkinson's. Do people know what they are? Drinking coffee and smoking cigarettes. This data from the Physicians' Health Study, where male physicians were followed prospectively over a couple of decades at the School of Public Health, Dr. Asherio and colleagues, and you see a reduced relative risk of Parkinson's with increasing amount of caffeine consumption and a further reduction in those male physicians who were smokers. So the mainstay of treatment is the replacement of dopamine, which is what is lacking in the brain, what contributes to the motor symptoms and signs. And that works very, very well at the start. As our patient described, the response was amazing. We often see substantial benefit in terms of reduction, slowness, and stiffness and tremor. By 5 years, there's often a degree of variability over the day and how people respond to this medication, such that towards the end of it's got a serum half-life of only about 100 minutes, and towards the end of a few hours, patients begin to experience the loss of benefit, the return of symptoms. And one of the principal issues in care of these patients in the second 5 years is trying to maintain that stability of motor response that they had at the beginning. There are also a lot of non-motor symptoms besides stiffness and tremor that contribute to disability in Parkinson's and impact quality of life. Apathy and fatigue are often cited in patients' surveys about their quality of life, along with a number of other things like drooling, sweating, dysphagia, GI motility disorder, problems with the autonomic nervous system, which of course do not respond to dopamine replacement and levodopa, and mental status changes, which often occur particularly in more advanced disease. This was an interesting study published 2005. It's a follow-up study of a group of patients who were in a clinical trial 15 years prior. It was a study of levodopa versus bromocriptine to see which would be the more successful initial treatment. And then the authors said, this was published in Sydney, Australia, said, let's get hold of these patients 15 years later and find out how they're doing. They almost universally had fluctuations in motor response and involuntary movements, motor response problems, like we mentioned. But that wasn't what was really bothering them. What was bothering them at 15 years was difficulty with their mobility and balance, falls, injurious falls, fractures, loss of independence resulting in nursing home placement, 40%, cognitive impairment meeting DSM criteria for dementia, 48% at 15 to 18 years, and a number of troubling problems with the autonomic nervous system. So this leads us to where we stand today, some of the unmet needs, what we need to address to do a better job with these patients. We need a better biomarker or diagnostic test to help us confirm a diagnosis in uncertain cases and follow patients better. We have a lot of good medications to replace dopamine. We need better medications we need a way to slow disease progression, to retard neurodegeneration, so that the amount of disability that people accrue at the end of 15, 20 years could be stretched out to 30 or 40. Would certainly be helpful for a disease that often begins later in life. And then some of the other unmet needs include treatment of non-motor symptoms, cognitive behavior changes, and of course, posture and gait, balance and falls. That's wherein we particularly need your help. So with that, I will turn this over to Dr. Madore, who helped us with this patient.
Thank you, Dr. Sudarsky, and appreciate the promotion to doctor. I'm actually a massage therapist. I appreciate that. If I can get some more pay with that, that'd be fine too. And thank you, Don, for your remarks, particularly the relationship of suffering, quality of life, and hope, because those are things that I work with. And so this is Madeline. This is how I see Madeline. And she doesn't look particularly stooped over, but in her perception, she is stooped over. And I think for a minute, what I'd like for you to have is an experience of somatic empathy for this particular situation. So imagine, if you will, what it'd be like to have a wetsuit on, like a scuba diving wetsuit, in which the front panel was shorter than the back, and it covered every square inch of your body, including your face. And imagine what it would be like with this wetsuit on, how you get through your day, how you'd raise your hand to comb your hair, to walk, to go from sit to stand. Those last few inches of getting to standing become more difficult. Getting out of bed can be one of the bigger challenges. It's probably not mentioned too much in the literature. For Madeline, that was one of her biggest issues, was getting out of bed. And you'll see that. So when I saw Madeline, I put my hands on her, and when I did, I tried to get a sense of how much effort she was using to stand up. And she was using considerably more effort than she needed to. And that was a factor in one of her second complaints, which was fatigue. So with this wetsuit on, just imagine at the end of the day, with every movement, there's that much effort. So her three main complaints were posture, as Dr. Sudarsky mentioned as the main complaint, or very typical of Parkinson's patients. And you saw her posture, and hopefully we'll do some things to improve that. The second one was fatigue, and the third was getting out of bed. And the process that I use, the modality that I use, is core movement integration. And that's particularly interesting because although there are some papers that have evidence of a number of modalities, Feldenkrais, Alexander, neuromuscular therapy, there's virtually no research and no published research on combined therapies. And core movement integration is a combination of working with the tissues, myofascia, and working with the way people use those tissues, how they organize them. And it was put together by my friend, colleague, and mentor, Joseph Delagrati, here in the front row. And Joseph was a student of Moshe Feldenkrais, who coined the term awareness through movement. And his concept is we don't stretch tissue, we stretch brains. So the idea is that it is a mind-body, or at least certainly a brain-body awareness process. And the second person Joseph studied under and influenced this work is Ida Rolf, the founder of Rolfing, who did tremendous work with fascia. And she coined the term structural integration. So those are the influences around which this process I'm going to use with Madeline, that's the resources that I brought to bear. And it's done individually, as in the case with Madeline. It's also done in groups. There are classes as well. So this is just a simple flow diagram of the relationship of form and function. Ray kind of relates to that. And I don't know how to get rid of that little thing. But at any rate, form and function. As an example, the form might be the tissue in the front of the body, and the function might be to lift your arm over your head. Okay? We all have to do that. Put dishes away, whatever. And by affecting, by using, in my case, I use my hands to affect the tissue, I affect how she uses the tissue, or at least her ability to use it. Now, I did a lot of things to raise my hand. In fact, raising my hand, if I don't organize it, this is as far as I could raise my hand if I don't use my shoulder. If I use my shoulder, I get this far. If I use my ribs, I get this far. If I use my hip and move my hip, I get this far. If I didn't use that, if I was to try to bring my hand this far back, it's a lot harder. And this is one of the key things that is lost in my experience with Parkinson's people is they lose their sense of organization. When I ask Madeline, what is your strategy in standing up? She says, well, I pull my shoulders back. And if that doesn't work, what would you do? I pull my head back. And I said, would you ever use your legs, Madeline? And she said, no, like it never occurred to her. Not only wouldn't it have occurred to her, but when I put my hands on her, the connection between her legs and her upper torso was non-existent. I could not move her head. With all that I know, I could not move her head through her leg. So I can work with the tissues that improves their ability to do certain actions. And it's through the movement process, the whole body movement process, I'll give you some inkling of, that reorganizes not just the movement, but reorganizes the thinking of the movement. Throughout when I'm working with her, I will use this mantra. You have 2 eyes, 2 arms, 2 legs, a head. How are we going to use them? How could your left arm help your right arm? How could your leg help your spine to help your arm? And the arrows go in both directions because the more you use it, the more facile your brain is, and the more likely your tissues will stay more supple. So here's a simple diagram from Tom Meyer's book, Anatomy Trains, of some fascial lines. So you'll see me working a little bit with this line, and you'll notice right in here that the front of the body includes the leg. And in this particular illustration, the leg is the inside of the leg, the thigh, the adductors. And one of the problems in bradykinesia is, and shuffling gait is those muscles can't lengthen. And in all 4 of the Parkinson's patients that I'm currently working on, they all have the same configuration. All of these muscles are folded in, and they resist going out, which makes it impossible to access them to stand up and to have a normal gait. But the good part is this is changeable. On the second one, this is the back line. And notice again, it goes all the way down to the feet. I have a lot of access to improve how a person stands up. From the cranial fascia, the neck fascia, the spinal fascia, it's all continuous. Everything I do in the front going up, and everything I do in the back going in the opposite direction supports upright posture. Now, in cases where I'm emphasizing the fascia part, I will have a person draped accordingly. You can see me working on that inside thigh. My intention is to get her to stand up and stand up better and to use those legs. In the second picture, you can see me with one hand going down the back. And here I have, in this particular picture, I have a hand on her arm, and I'm trying to get her to move her arm as the fascia in the back goes down. So there's a number of things that I'm doing here, because there's fascia. There's a fascia of the pecs, there's fascia of the abdomen, there's deep fascia in the psoas, all of which contribute to, if it's tight, it contributes to forward posture. If it's looser, it contributes to more erect posture. So the process that I use is I look at a person, I put my hands on them. How hard is it to create that movement? I put my hands on the tissue. I see how that tissue moves. Typically, it'll move. The direction of ease is going to be that supports their posture. So if I push down on the front, that's what's going to be easier for them to go. You push up, it's hard. It's hard for me to move, and it's hard for them. That's the resistance to life. Once I get a sense of the tissue and the effort and I can't move a person from their leg, I can't move a head from their ribs, etc., then I put them on the table, as it's always much easier to work out of gravity, and I will do certain sequences of movement in order to have this person aware of the possibilities of the leg helps the pelvis and the pelvis helps the spine, etc. So there's a tissue lengthening, there's movement, and then I have the person, this is probably the most important part, I have the person take ownership of the movement. So it's not good enough that I can do it on the table, and they can do it with my assistant. They have to own it. So they perform the activity, we discuss the process, and in the case of Madeline, I made a video and we put it on an iPhone. Great new technology. I mailed it to her, and then she practices it. And that worked very well. So we're going to show you some results of that process. All right. So this is her initial strategy in getting out of bed, her main complaint. And, whoops. And how do you play it? Lying in bed, and how are you going to get up differently than you usually get up? Oops. This is the 2 arms, 2 legs.
2 eyes.
2 eyes. Yeah. See, I need some more integration with the machinery. So what you're going to see is an initial. This is how she typically gets out of bed, or did. How you used to get off the table or off the bed without hurting yourself.
It was like a struggle.
It's like a struggle. All right.
And then grab something.
Right. So you're taking the heaviest part of you and kind of leading with that.
I guess.
Right? Then you grab a hold of something, and this is where you kind of fall out of the bed. Okay. Oh, good.
That was all the time.
All the time. Now, could you show? That was all the time. And the comment I made, that was the heaviest part. Previous to that, I lifted her head, and it wasn't, her head weighs 10 pounds. Her head, I would say weighed 20 pounds. Why? Because she was pushing it back. She was doing the same thing lying down that she did all day long. She was trying to stand up straight. So even in sleep, she was creating her own wetsuit. So now I'm going to show you a video, and this is no longer Madeline. This is her stunt double, my wife Kathy. And the reason why is Madeline is away visiting her family out of state, so I didn't get a chance to do this video. So This just gives you an example of just a very simple, there isn't much in the way of therapeutic intervention because of the time element. I wasn't going to show how I would correct every little difficulty around how problem with the leg doesn't move, what I would do. But this just gives you an overview of what it would look like. And when I do primarily movement, the person is fully dressed. And I can do some faster work, but it is easier.
Integrate the lower body to the upper body. I'm just taking a simple move that you may see on the video later on. But we're just rolling back and forth, a simple movement. And there's a leg part of the movement, so I can get the leg to move. And then you can move the leg, and the leg to the pelvis to the rib to the opposite rib, and then the rib to the arm. And then going in the other direction, you have the hip rolling forward. You might notice that there's some action going on, some flow of the leg.
That even
Flow
includes the foot.
meaning spiral.
The foot is moving relative to her leg.
And that if she was to reach across, to get the sense of reaching across and the ribs moving, the pelvis moving, and the legs moving. And there's a bottom side. So what you can't see is my bottom hand, making her aware of her bottom ribs rolling, the bottom hip rolling, and how that spreads throughout her body.
Oh, that's not my wife making those
And that's
sounds. It's my grandson. All right, now let's see when you add some fascial work with, something that looks like
In
something
bed,
you get.
and how are you going to get up differently than you usually get up? So you get 2 arms, 2 legs,
2 eyes.
2 eyes, and a head. So
Where's my knees?
you got your knees bent,
Roll over.
roll over. What are your eyes doing that they weren't doing before?
All my hand.
Right. Okay.
Down.
Good. And what are you going to do with your eyes and hand?
This hand, I'm going to watch it.
You're going to watch the hand.
Look at it this way.
All right. Now, what did you notice when you watched that hand? Did you find that you needed as much strength to push off of the other elbow?
No.
No. Great.
And I had not done that before. I
Right.
had not looked that way. I was always looking.
All right. Show what it would look like.
Okay. So some intermediary steps, I had to introduce a few things. It wasn't just telling her, I'll go to your side. I had to give her the sense of how to roll in the bed. Because she had previously told me she felt like she was pinned. And this was so compelling to me why I wanted to get this early on. I had this image, as she said, I was pinned to the bed. And she was like a turtle on her back. And that wasn't something that was very tolerable. And here's an example before and after. So this is how she came to me, and this is how I looked at her and what I did to change her. And in the second one, you can't see it, but she's using her legs a little bit more. And she's a little straighter. But most importantly, she's smiling. So I had an interview with Madeline just last week before she went away. And these are some things that she said, which I thought was relevant. It's not so bad when the meds wear off. I feel more energetic, which I think will help address some of the issues around the wearing off effect. So that because she's not working so hard while the medication is in effect, when it wears off, there's less of a drop-off. The second thing that I noted, or she noted, at least now I know there's another less strenuous way to do daily things. So this is a learning process. You can take any activity, break it down into its constituent parts, and make it easier. So that as the disease progresses and you get this progression, as Dr. Sudarsky would say, is, continued stoop, continued depression, increasing symptoms, you have at least something that you could control, some way of learning how to do things better that would have some way of your offsetting the nature of Parkinson's. And this is my most encouraging statement. She said, I hadn't raked leaves in years. I decided to give it a shot. It didn't bother me, so I did it more. She raked 3 bags of leaves, and normally her back hurts her. But I never asked her to rake leaves, but she felt like raking leaves. So, and she was successful. The likelihood of her going out and perhaps doing a little more yard work is a little higher now than it would have been. And what's exciting to me is that if I can help her to be motivated to rake leaves, and if I can help her to have a good experience raking leaves, can I help her go back to dancing? Can I get her to be more active with her children and her grandchildren? So, in summary, combining mindful movement, stretching a person's brain as well as the tissue, improves all the activities of daily life. Having a wetsuit that fits you and having a way of using your body to offset the lack of dopamine and all the other things that go on inside your brain, I think fits Dr. Levy's concept of changing the game plan. Instead of suffering with the disease, you have some level of control. So there's an expectation that you may be able to go through life in a different way. And of course, it's complementary to conventional care. As obviously, she's going to continue to take levodopa, and it's complementary to all other physical therapy, occupational therapies. And relevant today, perhaps it needs more, formal research, and we have some researchers out there, and maybe somebody would want to champion some further work on this research. And thank you. And now Helene is going to do her impersonation of Peter Wayne and introduce the idea of Tai Chi relative to Parkinson's.
Thank you so much, Art. It's really beautiful. And I'm going to try to do, is this on? I'm going to try to do justice to Dr. Peter Wayne's just remarkable approach to studying Tai Chi as a multimodal intervention, and Tai Chi for Parkinson's disease is a great example of that, as the work that he's doing in his research. And so this is a concept that Peter has put together, and I think it's really nice. I mean, as we've heard already, Parkinson's disease as an example, but of course Tai Chi is used for many other, therapeutically for many other conditions, but especially for Parkinson's, we know already this is not a unimodal. This is not just something that's just wrong with the substantia nigra. I mean, clearly there's a motor control component, important one in Parkinson's, but there's also, as Art was illustrating, a peripheral tissue component. There's a stiffness of tissues that sets in as people adopt a stooped posture for years and years and years, and the tissues respond and shorten. And then there's also a cognitive component to Parkinson's disease, and some of Peter's research really addresses that. And so this is a nice little diagram that Peter has actually published that illustrates how there's many different aspects of Tai Chi as a multimodal intervention that can really put together, dynamically interact in the treatment to address different aspects of the person's condition. So just some examples here. So musculoskeletal strengthening and flexibility, for example. Dynamic structural integration, as Art has explained. awareness, focusing one's attention, and then intention, and then finally relaxation and sort of dosing and moderation of one's effort. And so these are all aspects, as you can see, extremely relevant to what we've just talked about. And Tai Chi is a very, very ancient, 2,000-year-old practice. And there's all these different components to Tai Chi that kind of together help. And some of Peter's research is beginning to show this. Of course, there's other things here that are illustrated here. For example, social interaction, because Tai Chi is very often practiced in group. And there's a philosophy related to Eastern Oriental medicine of balance between the different aspects of life. And so there's such a very, very rich practice. And so what Peter has been doing is doing some very sophisticated studies in Tai Chi that look at components of gait, for example, of balance, and show that Tai Chi actually has measurable effects on how people walk, how their center of gravity is focused, how they can move their center of mass with different amounts of ease. And also the latest thing he's interested in is the cognitive motor interactions. When people, for example, walk and are asked to do a mental task at the same time as they walk, their gait deteriorates. And with Tai Chi, they're better able to, for example, carry on a conversation and walking at the same time. And they can actually measure this. And this is all part of the very complex system of neuromuscular interactions that are being helped by using this therapy. So now we're going to play a little video that will illustrate some of this.
Learning that I had Parkinson's was devastating. Tai Chi enabled me to build a relationship with my body again.
Tai Chi teaches you how to make your movements more graceful, so I feel more at ease.
When you see your body relaxing, it does make you feel better.
With your upper arm, just gently forward and stretching. Switch. Parkinson's disease is the second most common neurodegenerative disease after Alzheimer's disease. For some time, I've been suggesting Tai Chi as an alternative to conventional physical therapy, as an intervention for people with Parkinson's disease who are experiencing balance difficulty. With a greater awareness of the effectiveness of it, we are recommending it earlier. Moving down into your legs and feet and toes. Feel them breathing too.
Tai Chi is commonly referred to as a mind-body exercise, a kind of meditation in motion. It integrates slow, relaxed, circular movements with deep, conscious breathing and a number of cognitive skills like focused attention, whole body awareness, and it uses imagery and visualization. The goal isn't to learn complex sequences of external choreography, but rather we use simple movements that allow people to focus on the core principles that we believe are most therapeutic in Tai Chi.
It engages me in a way I've never been engaged, the kind of movements you do or you don't do in anything else, you don't do in any other sport. What I enjoy so much is the sense of connection to my body, the ease of doing it, and the relaxation and sort of confidence of balance that I feel at the end.
What's cool and different about Tai Chi is the fact that it's very non-stressful and very quiet, very graceful. And what I enjoy mostly about it is that it's converted me to a large extent from being focused on what happens next rather than being mindful of the present.
One of my challenges is I have significant tremors in my left hand and left leg, and the Tai Chi helps to relax the muscles. I notice a benefit right away seeing other people with the similar conditions. Makes me feel like I'm not alone.
With Parkinson's, there's a reluctance sometimes to be social, and couples suffer. Being together, having fun in some kind of a program like Tai Chi, where both people have a shared experience that is a positive one and even a fun one, is extremely important.
If I have any anxiety about Jim's condition, then it's certainly I'm able to relax. But I think also as a spouse, it's a way that we can support each other and be in a group setting that's safe, and it's just a very nice group of people to be with.
And she doesn't feel like going backwards anymore. She's going to roll me off to her right, and our hands are going to go roll. And now her hand is
There's a growing body of research evaluating the health benefits of Tai Chi. To date, there's probably more than 150 randomized controlled trials, and there's some good evidence that's emerging from this literature.
And there's one published study that documented that 6 months of twice-a-week Tai Chi with an emphasis on balance was able to improve balance, and they compared those patients to two other groups, some patients that had conventional exercises. And it wasn't even close. The Tai Chi group had benefit that was measurable compared to the non-Tai Chi groups.
All right, very good. Thanks for coming. We'll see you next week.
I'm 5 years into this disease, and I have pretty much no doubt that I'm doing as well as I am because of Tai Chi and all the different movement programs I'm a part of.
I would recommend it completely to anybody who's newly diagnosed or is the spouse of somebody or a friend or a family member of somebody who has Parkinson's, because you'll reap so many benefits. The health benefits and the support system is really fantastic.
We have 5 minutes left, so we thought we would sit down here and answer any questions, comments, and Helene can continue to impersonate Peter from the audience if she needs to. We are? Okay.
And just turn the mics on.
Okay, any questions? Amen. Yeah.
So there are, are you the mic? All right. Oh, okay. So there are numerous stories of people who, before they were diagnosed or had any symptoms, did things like playing ping pong, which they were pretty good at. Later, as they were diagnosed and as the disease progressed, they still played pretty good ping pong, which seems surprising because it's kind of a delicate type of sport. And I'm wondering if there's, number one, if you've heard other examples of this sort of thing, and if there's an explanation as to why that is so possible.
I guess the easiest way to think about it is the substrate for motor control that's involved, which is different for different tasks. So, for example, I guess one of the best examples of this is bicycle riding, which is often used as a modality in rehabilitation. But we have colleagues in the Netherlands who use bicycle riding to rehabilitate patients. They have patients who can barely walk across the room, who can then get on the bike. And there's videos on YouTube that illustrate this, that then get on the bike and do swimmingly, a thing you would think that they would have a hard time with, right? Because it requires balancing the bike and moving the legs. So there's often disparity between different motor routines, and things that you've learned and practiced well, you may be able to retain. I guess that's the perspective I would put on that.
Well, sure. What brings to mind a story that was in Norman Deutsch's book on how the brain heals itself, and it was the matter of simply drinking a glass with a tremor. And the person was complaining that she had a difficult time getting a drink. And it was suggested that she do it in a more mindful way. And she says, reach around to the other side of the glass, which now you have to think about what you're doing. And you could drink in that fashion, and there was no tremor. So you can read about that. There's a good section of a very interesting case of how one man overcome Parkinson's through mindfulness. And he may be coming to Boston, as a matter of fact, John Pepper. I've invited him.
Have you done any research or looking at thoughts about and where acupuncture might play a role in any treatments?
I can say that I have literature on it, and for many people, my approach to all such modalities is what's your goal? Well, I want to try to reduce this tremor. So let's go to an acupuncturist who's worked with Parkinson's patients and ask them how many sessions might be needed. I need at least 6 or 10 or 12, and let's try it and see if you're a responder. And I'm always surprised. There are people that say, I don't even like needles. No way. Okay, I'll try it. And they respond remarkably well. And others, acupuncture has helped them in 9 other ways, but it didn't touch the problem at hand. And I don't know how to be any more scientific than that, than to do limited therapeutic educated trials.
One thought that a psychiatrist often has listening to a presentation like this or thinking about Parkinson's is what the effect is on a person of having less and less dopamine, because the general thinking from a or a psychopharmacological point of view is that dopamine is largely involved in pleasure or the reward system. And it seems that in watching Arthur's work with this woman or the Tai Chi video that the patients in their, kind of their stiff wetsuit, they're less and less able to initiate an activity that they anticipate is going to have some reward or some pleasure involved in it, and that by reintroducing, a kind of mindful movement or a Tai Chi movement or ways to strengthen or to stretch their myofascial tissue, I just wonder if there are other sources of dopamine in the body that are activated, or what a neurological perspective would be. It seems like there are these resources in the body that are hard to tap when your condition is sort of being increasingly encased in a kind of Parkinsonian progression.
I don't actually have a good answer for how physical interventions help release dopamine. We know that motivational state can help release dopamine. It was an older observation, for example, before dopamine replacement was even introduced into medicine, that patients with Parkinson's disease in the nursing home, where they often were found after 5 or 6 years of their Parkinson's disease. When there was a fire in the nursing home, these were the patients who got up and carried everybody else out of the nursing home. That extra motivational kick was from the limbic system, was enough to release dopamine in the motor system. But the other connection, I don't have a good way to make for it.
Yeah, I'm Tai Chi, absolutely. I've been a practitioner for many years, and I studied with Feldenkrais. I think I don't know where the real, key to unlock, the code to unlock the Parkinson's and other disorders are similar will come, but I think the neuroplasticity is the one that has the greatest potential for me, because that's how I think the change takes place. The brain is perceiving new tracks, and the plasticity factor organizes a new pathway. And since you've got 90 billion neurons running around, you might as well use them. And any kind of organized movement which involves mindfulness and intention is going to be the greatest single combination. Plus exercise. I think exercise has been shown to be the greatest stimulant to the brain known to human beings. So all those factors, when they come together and we put it together and we find the right balance, I'll bet we're going to get a lot more successes with all of the neurological disorders, including all the other postural disorders as well. I'd like your comments on any of the neuroplasticity. It wasn't emphasized a lot today, but I imagine it's there.
Oh, sure. Of course, we're learning a lot more about neuroplasticity, and there certainly are changes, positive changes in the aging brain, where people can learn to make new connections and learn motor routines. I don't have enough information about it to make the connection clearly between the 2 points.
Okay, thank you very much. I hope you got a sense of the disease and the illness, and we're going to break and we go across the hall. There's coffee and other snacks. Coffee to prevent Parkinson's. There's no smoking. But thank you.
Thank you so much, everyone. I want to remind everybody that our next presentation is going to be on Tuesday, January 5th. And our presenters is going to be Dr. Louisa Silvia, from Mass General Hospital. And if you have not signed your name on the sign-up sheet on your way in, please do so on your way out. And we'll see you at the coffee hour across the hall. Thank you.